microphone on.
Check
So good morning. So yesterday we performed 2 D3 right hemicolectomy. So let's discuss a little bit about the steps of the right hemicolectomy, when it is required and how it should be done precisely. So this was done by the BPKM system in 2 cases we discussed yesterday. So it's the Japanese classification. According to that of the Japanese Association or Japanese Society of Colorectal Cancer Surgeons, they have performed this type of lymph node mapping for the colon and rectal cancer. So if you see for the right-sided tumor, this is for the right-sided, not for the left side, since we will be talking about the right-sided tumor. So this is the right, if the tumor is located somewhere here, so according to them, it is classified the cecum 201, then it comes to the 202, then comes to 203. It means this is the pericolic lymph nodes according to the European or Western classification. 202 is the intermediate group of the lymph nodes, and 203 is the principal or the central group of the lymph nodes. So on the basis of that, they classify whether you do the D1 dissection. It means like the gastric cancer also, when we dissect out only the pericolic lymph nodes. D2, when we take out this central, this is the intermediate group of lymph nodes, and D3 when you take out the apical or the central group of the lymph nodes. So on the basis of that, they have classified it as the D1, D2 and D3. If we go to the Eastern society, they are very much prone to us performing the D3 dissection because they believe in a radical surgery. If contemporary radiation therapy and surgery has to be done, they prefer the surgery or one of them, not both of them. So now there is another concept of the CME, like the TME for the rectal cancer. So similarly, the total mesocolic excision. So they are 2 different entities actually, but they can be done at the same time. CME means that achieving the going into the embryological plane and achieving a good quality specimen, but that doesn't definitely mean that you have to take out the D3 group of the lymph nodes. So CME means at least you can do with the D2 dissection or D3 dissection at the same time. You can remain in the embryological plane. So there are a lot of controversy regarding that, but right now we must focus that for us the best thing is to do the CME, and the next thing is to select the patients for whom we can perform the D3 dissection. So now let's go ahead. So according to the Japanese society, they say that if it is early stage disease like carcinoma in situ, T1 disease or T2 disease, and if they are not negative, then there may not be any benefit of performing the D3 dissection because there are several morbidities. Even you can cause the mortality because of the extra radical surgery without any additional benefit. But they say that if it's something beyond T2 like T3, T4 or T4B, or the nodes are positive, there are high chances that the central group of lymph nodes or the apical group of lymph nodes will be positive. So unless you do not dissect that, there will be the high chance of regional recurrence and also the distant dissemination at an earlier time. So they recommend that the D3 dissection can be done for this group of patients and this node positive patients. So according to them, but European society, they have said because the pattern of patients are different in the European or Western society, because they are quite obese, it may not be so easy to do the D3 dissection for them, because there are a lot of chances that you can injure the superior mesenteric vein, lot of chances that you can misdiagnose, like it is the superior mesenteric vein, but actually this middle colic vein you are ligating, but actually it could be the superior mesenteric vein. So these things can happen in the very obese patients that are peculiarity for the Western society. There have been 3 approaches. Definitely we can do the vessel first approach. That is very good, like in the laparoscopy stage we do from the medial to lateral, but there is at the same time we can do from lateral to median, like in most of the open surgery we prefer to do the lateral to median, and also sometimes we can do from superior, remaining the lateral to median, but open up the gastrocolic ligament first, find out the pancreas, uncinate process, from that go duodenum, and from that moving downwards. This can be done also. Very important in such cases is to remember the anatomy of the superior mesenteric vein and all the vessels. Quite difficult part is this one. Very often we stuck to the loop of Henle or trunk of Henle even during the pancreatic duodenectomy. The same thing is true also for the D3 dissection, and that is a requirement for the D3 dissection. So you can see here a lot of variations can happen. So this is the gastrocolic trunk. The jejunal veins can arise here. At the vicinity, there will be the superior mesenteric artery here. So we must be very much clear that sometimes what happens, this vein, jejunal vein, maybe J1 or J2, whatever, larger veins, that may run anterior to the superior mesenteric artery, or sometimes they may run posterior to the superior mesenteric artery. So that is very important to remember. Like in this picture, this gastrocolic trunk has given two branches, the right gastroepilic vein and the colic branch, right superior colic vein, that is draining and forming the gastrocolic trunk. Quite often we have the SPDA, superior anterior pancreatic vein, which also drain into the gastrocolic trunk. There are various variations of the GCT as shown. It can happen that trifurcation variant, that is the pancreatic branch, this is the colic branch, the gastroepilic vein. Whether at sometimes only the single GEV may be present, gastroepilic vein, or even middle colic vein may be draining into the gastrocolic trunk. So different variations we have to find out during the surgery. Like here in the picture, it is said that is the classical variant of the middle colic vein, which is draining into the superior mesenteric vein. But here we can see the middle colic vein is draining into the splenic vein. Or here we can see the middle colic vein is draining. This is the middle colic vein. This is draining the GCT. So different variations may happen during the in a patient. The same picture diagram, we should be also very much clear about the possibility of existence of the right colic vessels. It's not always present. In 20% of the cases, it may be present. Rest of the patient, it may be absent. So it's also not very essential, but if you remember them, it's very good. And also the very good thing is that this artery, like this superior right colic artery, in this picture, it is crossing anterior to the superior mesenteric vein. So why it is important? Because while taking out these vessels, it's very good that logically we take them separately. Sometimes we take en bloc, so that may compromise in some way the lymph node dissection. If we take together, that may be better for the patient. Similarly, if we take an attention to the ileocolic vessels, in this particular patient, the ileocolic artery is crossing anterior to the superior mesenteric vein. So these things, if we know preoperatively, that's very good. That can be done known preoperatively. Also for that, we need a good 3D reconstructive image. Here are the similar things, different variations that I have talked about. The jejunal veins, I said sometimes jejunal veins go anterior to the SMA, sometimes go posterior. Here it is going posterior, here it is going anterior to the SMA. The same thing, right colic artery. Right colic vein could be different. I said that most of the time they are absent. There could be a single right colic vein, there could be two right colic veins, or the right colic vein may drain into the gastrocolic trunk of Henle. So there are different patterns which might happen. It has been shown in the same picture here also. Middle colic artery, quite often we see the middle colic artery is formed of the right branch and the left branch as shown in this picture, and they join together to form the middle colic artery. There could be variations, not like this Y-shaped, maybe like this one, the second picture, or maybe quite peripheral, that will be going closer to the colon also, or transverse colon. So this is very good if we have the software or even the artificial intelligence. Preoperative, we may know all the structures, all the vessels, like has been shown in this picture. If we can obtain this kind of picture, that will be very helpful for us during the surgical procedure. The same thing, only one thing we must remember for D3 dissection, we just imaginary line from the falciform ligament go to the root, like this. So if you draw this line, approximately this will be coinciding, just behind that, on this line, like the cantering line for the median hepatic vein. So this will be the line where the superior mesenteric vein or superior mesenteric artery will follow. So we can just imagine it during surgery, we can take this guidance. And also during D3 dissection, it's very important not remaining very close to the ileocolic vessels. So we have divided into zone A and zone B. Zone A means we are going very close to these vessels. We are ligating, so it's safer to be a little bit farther away from that. So in one way, we are not damaging those vessels. On the second way, the lymphatic clearance will be better. So like in this picture, it has been shown the SMA, SMB, ileocolic vessels in an open surgery. We remain not in the zone 1, it's very close. We try to remain the zone 2, which is a bit farther from the ileocolic vessels. So it will be difficult for us to injure those vessels. Similarly, at the end, we have to achieve this kind of the pictures. This is the same thing, only one thing that is Dr. Sagar is very fond of talking about this Gillot trunks or surgical trunk of Gillot. It means it's very good to know about this. This is the trunk of Henle. This from the ileocolic vessels. This region, we can call the surgical trunk of Gillot. So it's said that generally it is 44 mm. It would be also good research point if we perform the D3 dissection to measure how long it is. And they say for particular D3 dissection, we should remain from the left side here and go here anteriorly and the medially assembly. This should be all clear. At least this triangle has to be clear. This trunk has to be clear completely. So this is called the D3 dissection according to Japanese protocol. What is very true, as per the Professor Hill, he has discovered the total measure TME for the rectal cancer, total measure rectal excision. Same principles can be applied for the CME. It means total measure is mesocolic excision. So for a surgeon, it's very good to have a good quality of a specimen. If you achieve a good quality of a specimen, then it minimizes or maximizes the R0 dissection. And also, there is the bloodless field, you can enjoy the surgery rather than going into the messy field. So if you compare in the left side of the picture, it has been shown the conventional or the D2 dissection. We can see only small part of the mesocolon or mesenterium has been excised. Whereas in this way, here a lot of mesenterium or mesencolon has been excised. So we can just visually compare D2 versus D3 dissection in this patient. Similarly here and similarly here. So this is the case yesterday was performed by our team. So just have a few minutes of attention.
A case of adenocarcinoma of hepatic flexure in 33 years old female patient. We have performed D3 right hemicolectomy. Here are a few basic steps of the surgery.
So we can see here we are working with the ileocolic vessels. That is the ileocolic vessel. This is the ileocolic vessel which has been there. This is the superior mesenteric vein. This one. So now we'll be ligating the superior mesenteric ileocolic vessel. This is the incident process.
The root, the middle colic vessels.
These are the medial colic vessels. Now this one, we're trying to find out the medial colic vessels. Everything is very clear, and we can see also the jejunal veins, very large jejunal veins you can see here, right?
Extended hemicolectomy will perform because the tumor is located in the hepatic flexure.
Cut it.
So we are going towards the left side of the transverse colon. These are the vessels to the terminal ileum. The assembly.
So this is the assembly.
The course of the D3 dissections, the all lymph were cleared along the up to the left lateral border of the assembly, right? So okay, very good. Now a staple has been cut. Now another staple will be used to seal that off. The gastrocolic ligament is being opened. The momentum along with the lymphatic.
So it was just a small video. I know you Melissa has a